guys, welcome back. The topic we're gonna study now is bronchiectasis. This would be characterized by destruction and dilatation of the proximal and medium-sized bronchi. Now, mostly in the exam, because they love to ask about the definitions as well. So they definitely can ask you regarding the diameter of the medium-sized bronchi, and I want you to remember that value would be more than 2 millimeter. Do remember the fact that when it comes to chronic bronchitis, which is common with smokers, the area of the lung that would be involved would be bronchioles, but here we are primarily talking about proximal and medium-sized bronchi. So traditionally there will be purulent sputum present in this patient, or he might say the word purulent bronchuria. Now my point is purulent bronchuria can be found in chronic bronchitis, it can be found in bronchiectasis. On a comparison basis, chronic bronchitis is much more common as compared to bronchiectasis. And one of the reasons why bronchiectasis has become relatively a rare pulmonary disorder is primarily because of ease of availability of antibiotics, because majority of cases would be related to infection, and considering the advancements in the field of antimicrobials, high quality antimicrobials being available at relatively cheaper prices, wider dissemination of healthcare services, so this disease has become much rarer as compared to what it was 50 years earlier. When I was a student to your age, I used to study bronchiectasis grading like mild, moderate, severe, where we used to actually quantify how much is the amount of mucopurulent sputum being produced by the patient. It may not be purulent all the time, but at least bronchuria would be present. So we used to quantify it as less than 10 ml, 10 to 150 ml, and more than 150 ml of sputum being produced by the patient on a daily basis. But now all these things are, not usually seen. I mean, I would say like this, that because of the usage of antimicrobials and multiple other strategies that I will discuss with you, I mean, it's not only about antibiotics, it's about multi-pronged approach that we use for these patients. So we are usually not seeing, I would say, moderate to severe cases. So most of the cases, disease severity wise will also be of the lesser grade, and the disease itself has become relatively rare. I highlighted this statement primarily because I used this word. I said bronchuria or mucopurulent sputum is one of the highlights of this particular disease, but he will surprise you in multiple choice questions by stating this term dry bronchiectasis. Now, this is going to be totally dramatically, diametrically opposite to what I was saying initially. I mean, when you read the word dry bronchiectasis, you suddenly start wondering what really happened. On one hand, we were studying bronchoria in the textbook, now he's saying dry. Well, dry bronchiectasis is commonly seen with tuberculosis, and this is also important from the perspective that usually in bronchiectasis there is presence of mucopurulent secretions, which by gravity will usually go down. So this disease primarily will be involving the lower lobes of the lungs. But when it comes to dry bronchiectasis, which is caused by tuberculosis, you very well know TB would be having a predilection for the upper lobe of the lungs. So you can understand the importance of this term that I've highlighted right away. I would like to put this on record saying that the lower lobes are the ones which are usually involved. If lower lobes is not given the options, then it's usually going to be the right middle lobe. It's mainly because of anatomical reasons that I am saying. So you see, due to gravity, lower lobe, if not, then the way the bronchi and the tracheobronchial tree is anatomically oriented, it is the involvement of the right middle lobe. Subsequently, another part that could be written is the lingular. So if all three are given, you will say that all these parts of the lungs can be involved. But don't be under impression that you cannot have bronchiectasis of the upper lobe. I'm going to teach you lobe wise when or in which disease upper lobes would be involved, in which of these it's the middle lobe that would be involved, and then another peculiar term would come, that is central bronchiectasis. So lots of data to come subsequently, but I want you to keep your mind open for the fact that because I have said this statement, which is more from a pathology book, because in earlier times when patients used to die, they used to evaluate the lung specimens. We found that these are the areas that are involved, but I have already sensitized you to the fact that even the upper lobe and the middle lobes can be involved. Now, from the histopathological perspective, they can definitely incorporate, because nowadays is the era of integrated multiple choice questions. He can definitely incorporate which is the commonest histopathological subtype, which you very well know would be the cylindrical variety, or would be also referred as the tubular variety, and is responsible for the classical tram track appearance that can be seen in these patients. In fact, I would just like to zoom into this image and give you a marking here so that you can relate to this tram track image that I am pointing to. But now just look inferiorly where I'm marking at the movement, the anatomical orientation is slightly different. In fact, if I try to hand draw this before you, this would look like this, right? Then there's a constriction and then there's again a dilatation of the proximal bronchus. So I have incorporated in the same CT. In fact, in this patient, there's a mixed picture present. You're not only having the tubular variety, but you're also having a varicose variety. What I've just marked before you is having focal constrictions. So let's just write that down as well. You could be having cylindrical, and I mean, it's not that a single patient will be having only cylindrical, another patient would be having varicose. You could be having a combination as well. And then the third variety would be called as saccular variety, sometimes also written as cystic variety. So don't be surprised, because normally when you read about cystic dilatations, you read in or you think in terms of blebs or bullas. But even when it comes to bronchiectasis, he does describe the saccular variety slash the cystic variety. And for varicose, I'll just mention the fact once again. You will be able to see some of the nodular constrictions which are present may not be very symmetrically oriented, but you could have a combination of these histopathological formats as well. One of the big problems that can occur in these patients is the erosion of the airways, and surrounding the airways will obviously be blood vessels. So massive hemoptysis, because traditionally we read about massive hemoptysis with tuberculosis more than 600 ml per day. So massive hemoptysis can occur in these patients as well, though the incidence has become lesser. I gave you the reasons for that, easy availability of antibiotics, multi-pronged strategy being used. So massive hemoptysis as of today again is something which is relatively less commonly seen, and even if it is seen, the chances of death is lesser. Why? Because we have technology, we have strategies to handle this. I'm very well sure of the fact that all of you have solved this MCQ in radiology also, that what is the preferred treatment for massive hemoptysis. Then we're gonna use interventional radiology and we will go in for bronchial artery embolization for these patients. One of the important causes related to especially the upper lobe involvement in bronchiectasis. Remember, I told you even upper lobe could be involved, is cystic fibrosis or mucoviscidosis, which has been discussed separately in the respiratory section. And apart from this, I also want you to remember that in cystic fibrosis, there is colonization of the airways of the lungs by Pseudomonas aeruginosa. Once the colonization occurs and this organism forms a biofilm, even if you get or give the most advanced of the antibiotics for this person, you would not be able to eradicate this infection. So once the infection is, I would say in a permanent state inside the lungs, then the tracheobronchial secretions will continue to be produced, and local destruction, local damage to the elastic architecture of the airways, local damage to the smooth muscles of the airways would very much continue. When it comes to chronic bronchitis, he'll usually begin with a smoker. He can begin with a smoker here as well, right? But the point is, one of the important clinical differentiating factor, though you very well know, I mean, this differentiating factor may not be seen in all cases, but just a hint, from the perspective that if you read a question that begins by saying smoker with bronchoria, it could be either chronic bronchitis or it could be bronchiectasis. I will discuss clinical features subsequently, but right now I'm saying that if clubbing is given in the question, you read a question, says smoking, then says development of bronchoria, purulent bronchoria, mucopurulent sputum, exacerbations, he's going to make it sound like chronic bronchitis. But remember, chronic bronchitis does not have clubbing. Clubbing can occur in bronchiectasis. This is itself a rare disease. Clubbing, it's a rare finding which is found in this patient. But from the MCQ perspective, I repeat the statement once again. You get a question, even if it talks about a smoker with bronchoria with exacerbations, but says clubbing, do not mark on chronic bronchitis, because we do not get clubbing in chronic bronchitis, but we definitely get this in bronchiectasis. Again, I repeat, it's a rare disorder and clubbing is rather a rare finding in this. But from the MCQ perspective, yes, you should be bang on, should be in a position to identify and crack the question. Now, once you get these baseline data right, we will now be discussing regarding the etiology of bronchiectasis. We'll subdivide this into the focal variety and the diffuse variety before we go into the clinical domain. So let's look at why could you be having a focal bronchiectasis. One of the important focal obstructive lesions that could be developing in the patient could be an endobronchial tumor. You see, there could be two possibilities. Either the tumor could be originating outside the airways or pressing on it, compressing the airway, contributing to underventilation, stasis of secretions, or more importantly, the tumor could be growing inside the bronchus and therefore it will hamper the ventilation, it will hamper the clearance of the tracheobronchial tree. The bottom line is, whenever you have underventilation, whenever you have interference with the clearance of the secretions in the lungs, there's stasis, and stasis again predisposes, stasis of secretions predisposes to infection and local destruction. So apart from tumors, let's look at another cause which would be more relevant from a pediatric perspective. That would be a foreign body aspiration. But I want to, at this particular point of time, just say the fact that the underventilation and the stasis of secretions is contributing to this local destructive effect. For a cause which could be present outside the airways, I can say that this could be lymph nodes. You see, if a patient is having sarcoidosis, or a patient is having silicosis or even tuberculosis, the lymph nodes could be pressing on the airways, again contributing to impingement of the ventilation. Let's look at the diffuse causes now, and this would be a relatively a longer list, so you need to persist with me to remember the aspects. And after I will finish this, I'll say a very surprising statement which we as doctors, when we say to our patients, so patients get really angry saying, doctor, you ordered such an expensive workup for me and now you tell me that cause is idiopathic. Yes, guys, in Harrison, I'm quoting Harrison here, 25 to 50% cases of bronchiectasis are idiopathic. So we'll have a discussion and then we say 25 to 50% cases are idiopathic. So like we doctors are basically doing reverse engineering of a malfunction that has occurred in the human body. So it takes a while to actually get used to that reverse engineering component, and non-medical people are not able to understand the technical aspects. So let's dive into it. When it comes to diffuse, I can say one can be infections. Now by infections, I am not only talking about Pseudomonas aeruginosa, which can form a biofilm in cystic fibrosis, but I'm talking about a patient of Mycoplasma pneumoniae. This patient should have been prescribed macrolides, very simple, straightforward, but he did not come to a qualified doctor like you or me, or rather he did not go to anybody thinking that it's a mild infection, it will clear off. If a lung infection is not cleared off within time, then it can cause local damage, and that local damage can manifest subsequently in the form of bronchiectasis. So one of the important organisms is Mycoplasma pneumoniae. Though, as I said, I mean, with availability of azithromycin everywhere, at even the smallest of the chemist in the village will be having azithromycin available and he can dispense it to a patient. But still, I mean, this is one of the organisms which, if not treated, can cause local damage. After Mycoplasma pneumoniae, then organism comes up Bordetella pertussis. You very well know we call it 100-day illness. So the child would be having a lung infection, a lower respiratory tract infection for a substantial. 100 days is 3 months, right? So 100-day illness, if you're going to be having a slow ongoing infection occurring in the lungs, then definitely long-term manifestation can be bronchiectasis. And Pseudomonas aeruginosa will obviously take its position. And I also want you to remember that because nowadays we use tobramycin nebulization on a weekly basis in children with cystic fibrosis. So sometimes Pseudomonas may not be found to be the number one organism. And you would have noticed this pattern even in MCQs also, because he knows that in cystic fibrosis, the moment he will say cystic fibrosis, you will answer Pseudomonas. So the examiner's ego is hurt. So he says, okay, fine, I'll not ask you Pseudomonas aeruginosa. So in cystic fibrosis MCQs, you will read regarding even Burkholderia cepacia as well. So one of the causes can be infection. Second important cause can be that the person's immunity will be on the lower side. Now, obviously, apart from HIV, which is very standard, he can love to ask you regarding another cause that would be hypogammaglobulinemia, which explains the fact that when I'll be doing the workup of this patient, I will be rather ordering for total antibody assay, and I'll be doing a quantification, right? A quantification of the IgM levels, IgG, because we know normal values. If the antibody values are lesser, that can again predispose to development of infections in a patient. The subsequent cause usually given in the textbook is genetic, but I would reserve it for the next slide because genetic would incorporate specific disorders like cystic fibrosis or Carter-Necker syndrome, which will take a while. So let's look at a relatively, I would say, a less common one, but all the way important from the exam perspective. I am describing a patient who is having repeated recurrent micro aspirations into the lung. Now you need to listen to this part very carefully because I'm not talking about a comatose patient in your ICU who had aspiration. I'm not talking about an alcoholic, a druggie who took so much of drugs that he was knocked out and then subsequently had an aspiration. Because if you're having an ICU patient, in fact, I should write it down. If you are having an ICU patient or if you have a comatose patient and there is an aspiration in these patients, or during general anesthesia administration, if there is an aspiration, then it's Mendelssohn syndrome, or it could be development of even lung abscess. So the message is, and I've discussed this separately, especially with respect to pneumonia topic, that if alcoholic patient, he took drugs, he took alcohol, also a cocktail, and then he's unconscious for, let me say, 2 days, and he can end up with micro aspiration of his own saliva, so there could be lung abscess formation. Please appreciate the fact that I'm not talking at the moment with respect to aspiration of only the food contents in the stomach. I'm talking about micro aspiration that could be occurring. But then there are certain medical disorders which could be having not one event, like, somebody did too much of drugs and alcohol once in his life. I'm talking about a patient in whom the lower esophageal sphincter tone is substantially low, because of which the acid can reflux up. So the disease that I'm talking about here is scleroderma. Though scleroderma is also a autoimmune disorder, and autoimmune disorders are also mentioned in the as one of the causes for development of diffuse bronchiectasis, but I've included it here specifically to highlight the fact that people with scleroderma, since there is fibrosis in the lower esophageal sphincter, there is a decreased tone, so they are predisposed to recurrent micro aspirations. Then could be any patient who had a stroke and he is having a bulbar palsy, pseudobulbar palsy. Even in those patients, the gag reflex would be hampered, and therefore recurrent microaspirations would be occurring. So I want to highlight this fact once again. If you're having during anesthesia aspiration of stomach contents, it's chemical pneumonitis, it is Mendelssohn. But if I'm talking about micro aspiration, once in a lifetime, right? Once in a lifetime event in a person, that after Holi he took bhang and then he had this micro aspiration, lung abscess. But if it's going to be recurrent micro aspiration, that's going to be scleroderma. I repeat the facts once again because lots of students mess up between these. Mendelssohn syndrome / chemical pneumonitis is when the entire stomach contents during general anesthesia can be, aspirated by a person. Then could be micro aspiration that could be occurring, let me say, due to intake of drugs like bhang, etc. at any festival. And then subsequently, I said multiple episodes of micro aspiration that could be seen with scleroderma, and even with HLISA cardia. I mean, even HLISA cardia, we read about recurrent pneumonia episodes, and if they're not managed effectively, then bronchiectasis could be a complication that could be developing in these patients. Then I would like to mention rheumatological causes. So when you will read rheumatological causes, you will notice that even rheumatoid arthritis, because rheumatoid arthritis, not rheumatic, rheumatoid arthritis has rheumatoid nodules, and these nodules can be present in the lungs as well. Then could be Sjogren syndrome. So you will notice that when I do workup of bronchiectasis patient, I will be doing an autoimmune panel in the patient. Then would be inflammatory bowel disease. Less looks surprising, but inflammatory bowel disease also has associated joint involvement. And IBD patients who are having a joint involvement can be having lung involvement as well. And then I would like to mention IPF, idiopathic pulmonary fibrosis. Now, when it comes to idiopathic pulmonary fibrosis, a very surprising term comes up here. Because of the fibrosis component, there is distortion of the airways. That distortion of the airways will hamper the ventilation. It will hamper the clearance of secretions from the lungs, and therefore the patient would be having a traction bronchiectasis. So you can see I have taught you about dry bronchiectasis, tuberculosis, but if you read about traction bronchiectasis, it is idiopathic pulmonary fibrosis that I want you to remember. In fact, I want to use this opportunity to teach you two more causes of traction bronchiectasis that can be asked to you in the exam perspective. One of them is radiation to the chest. Like this person, he's received radiation for superior vena cava syndrome due to Hodgkin's lymphoma. Hodgkin's can have massive hilar lymphadenopathy. It's pressing on the SVC. So I gave radiation. The good news is radiation will shrink the lymph nodes. But the bad news is the radiation can contribute damage to the local lung parenchyma and cause a traction bronchiectasis. We also read this with sarcoidosis as well. So the message is that traction bronchiectasis is itself a multiple choice question which has to be remembered from the exam perspective, apart from the aspect of dry bronchiectasis, which is said relatively in the earlier part. Let's continue with this discussion subsequently. Next, I'm going to incorporate before you one of the important autoimmune causes. Now, you can say that rheumatological conditions are also autoimmune, so I agree to that. But specifically autoimmune, here I mean the immunity is acting up against the airways. Let me just describe it and you will be more comfortable. All of you have read this term ABPA, allergic bronchopulmonary aspergilloma. In this, there is a hypersensitivity reaction to a fungus by the name of Aspergillus fumigatus. See, this is not colonization of the airways. It is hypersensitivity reaction to Aspergillus fumigatus, which explains the fact that why for diagnosis of allergic bronchopulmonary aspergilloma, we do not use a sputum culture. Aspergillus can be present in sputum of you and me also. That does not mean we are having APPA. But the hypersensitivity reaction which is occurring in these patients will cause you to always answer serum precipitants against Aspergillus species to be used for diagnosis of these patients. Immunoglobulin E levels will definitely be grossly elevated. A lot of these patients might be having fungal hyphae on a sputum examination, but I want you to remember the fact that never mark on fungal hyphae in sputum examination as the best test for this condition, primarily because it's a hypersensitivity reaction. So I need to demonstrate that. I need to demonstrate the antibody levels are higher. I need to demonstrate that the serum precipitants against Aspergillus species are very high. And just to give more credibility to this statement I made, autoimmunity, this condition responds very well to steroids. Yes, guys, the exacerbations of allergic bronchopulmonary aspergilloma, in fact, I should jot it down here. Allergic bronchopulmonary aspergilloma would be an asthmatic. Why this asthmatic chap is being discussed in the topic of bronchiectasis is because this asthmatic patient, when he came to me, he said, boss, doctor, I am having brownish sputum plugs. First, I was thinking, come on, what are you talking? Brownish, blackish sputum plugs? He says, yes, sir, when I'm coughing out, after I take my puffer, I'm having those brownish or blackish sputum plugs, and I thought it is some infection. But later on found it was a colonization that is occurring in these patients. So I decided to run a HRCT in this patient, and a very surprising finding came up. That was central bronchiectasis. Now, when you say the word central, it does not mean that it is the middle lobe of the lung. Central basically means it is the proximal airways which are basically involved. So there is a hypersensitivity reaction with damage to mainly the proximal airway. That's the first word that I used in this discussion. I want you to remember a couple of terminologies before we proceed further to the genetic causes which will cause diffuse bronchiectasis. I repeat again, genetic causes which cause diffuse bronchiectasis. We need to here remember primarily the ones that I mentioned in color green. Dry bronchiectasis, I hope you are remembering it by now. Tuberculosis, upper lobe, right? Otherwise, traditionally it should be lower lobe, right, middle lobe. Another question I taught you was traction bronchiectasis, IPF. IPF mainly involves the lower lobes. Sarcoidosis mainly involves the upper lobes. Now here, people tend to start getting additional points coming up. Yes, IPF, that's a predilection that you need to remember. IPF, lower lobe, sarcoidosis, it's the upper lobe. And then radiation, anytime if given to the chest, primarily for relief from superior vena cava syndrome, can cause local damage. And after dry and traction bronchiectasis, I've taught you central bronchiectasis. One of the standard questions that they love to ask, central bronchiectasis is a feature of your spot answer would be allergic bronchopulmonary aspergilloma. And now we are going to be focusing on a more important component, that is genetic reasons why you could be having development of this disease. One of the important ones is alpha-1 antitrypsin deficiency. Now, alpha-1 antitrypsin deficiency is associated with emphysema. Here we are discussing bronchiectasis. Yes, guys, you could be having both a emphysema component as well as a bronchiectasis component developing an alpha-1 antitrypsin deficiency. Another one is cystic fibrosis, chromosome 7, F508 mutation, and then a disease where there would be a problem with the dynein arm of the cilia. So the ciliary motility would be hampered, Kurtenegger syndrome. When you read about alpha-1 antitrypsin, you need to understand it is produced by hepatocytes. Once it is produced by the hepatocytes, what is the function of alpha-1 antitrypsin? The main function is that it will neutralize an enzyme by the name of elastase, which is produced by the alveolar macrophages. And why are macrophages producing elastase? Pollution in our country. Not everybody is a smoker, no. People like you and me who are educated are not smokers. So, even if a doctor will smoke maybe once in his life just to see how it smokes, no. In medical college, that's what happens. Otherwise, nobody becomes a permanent smoker, or even if somebody wants to, that's a personal decision. But what I'm saying is, let us assume a non-smoker. If a chap is a non-smoker, the pollution in Delhi air, North India air, in fact, whole of India is so polluted, macrophages will be irritated. they are gonna produce elastase, and this elastase will be neutralized by alpha-1 antitrypsin. I repeat the fact once again, alpha-1 antitrypsin helps you neutralize elastase, which is produced by alveolar macrophages, which are irritated by pollution on a continuous basis. Now, what happens in alpha-1 antitrypsin deficiency is not that it is not produced. It is produced. Please remember, in alpha-1 antitrypsin deficiency, the production of the product is perfectly normal. It is the release which is defective, which means the fact that this is going to accumulate inside the hepatocytes. I repeat the fact once again. I said in alpha-1 antitrypsin deficiency, it is not that it is not produced. It is produced, but is not gonna be released out, so it will accumulate inside the hepatocytes, which will explain the first manifestation that occurs in these patients and is Arzt cirrhosis. Now, because alpha-1 antitrypsin is not available, the ability to neutralize elastase will not be there, so the bronchioles can be affected. The damage to the bronchioles will manifest in the form of pan-acinar emphysema. Even the proximal bronchi and medium-sized bronchi can be involved, so the manifestation can be now in the form of bronchiectasis. So this is the profile that you always get with alpha-1 antitrypsin deficiency. Let's compare this with cystic fibrosis versus Kaltenegger. Cystic fibrosis is a separate discussion, but I'll just mention some important highlights here. It's a F508 mutation. This is going to be defect on chromosome number 7, autosomal recessive. And what's the problem? The problem is that in this condition, the cilia will be beating normally. The cilia motility is perfectly normal, but the tracheobronchial secretions are very viscid. I repeat the fact once again, cystic fibrosis is written as mucoviscidosis. Why you read the word mucoviscidosis is mainly to highlight on the fact that the secretions are very thick. As a result of these very thick secretions, there would be stasis. And because of stasis, the bacterial infection would come in. Initially, the infection would be caused by pneumococcus or with Haemophilus influenzae. Usually in children, it is Haemophilus influenzae. But subsequently, because of repeated hospitalization, Pseudomonas would come in, Burkholderia cepacia would come in. And once these organisms will establish themselves in the lung and form a biofilm, there would be manifestations of bronchiectasis occurring in the patient. An additional fact which I want you to remember at this point of time is that cystic fibrosis patients can be having infertility as well. Let's just look into this data and I'll tell you the significance of it. Give me 30 seconds. Infertility is found in both the genders in cystic fibrosis. In a male patient, it is usually the cause would be agenesis of vas deferens. If you are wondering why am I telling you this, guys, this has been asked in the exam. Earlier we call it AIMS and now we call it INICET, but agenesis of vas deferens is an important concept that you need to remember for male infertility of cystic fibrosis. In females, the cervical mucus is very thick. You very well know cervical mucus will become thin. You read about Spin-Barkeet in physiology, right? Cervical mucus on day 14 becomes thin and stretchy, shows a fern pattern under the influence of estrogen. Here it's going to be thick, so it will interfere with the penetration of the sperms, and therefore infertility can be seen in both the genders. Now listen to this very carefully with Kaltenegger. In this particular case, it's the dynein arm, the cilia motility would be hampered. So the message is the problem is not with the tracheobronchial secretions. The secretions are perfectly normal. It is the ciliary motility which is hampered in this case, because of which there will be not only development of sinusitis, because our sinuses, maxillary or ethmoidal or frontal sinus would be having ciliated columnar epithelium just to keep the secretions in a constant state of motion or flux. But here the stasis would bring in sinusitis. Then these patients would be having recurrent pneumonias. Then these patients would be having bronchiectasis. And you very well know the fact that cilia play an important role in embryonic development. Because of the hampering of the embryonic development, if they give you a chest x-ray of a patient of Kaltenegger, there is going to be situs inversus present in a patient. There's going to be dextrocardia present in this patient. But now comes an important aspect. When it comes to male patients with Kaltenegger syndrome, yes, the sperm motility will definitely be hampered, because of which infertility will be there. But in a female patient, there will be no infertility in Kaltenegger syndrome. Why? Tubal peristalsis will be normal. You see, ultimately, the ova has to circulate via the tubes, and then there's a fertilization in the ampulla. So cilia obviously play a role. The epithelium, the fallopian tube is also ciliated columnar. But even if the cilia are not beating, even if the cilia are not beating, tubal peristalsis is very much there, and because tubal peristalsis is very much there, therefore I can say the fact that infertility would not be seen in these patients. I'm just putting a cross here to say I have done a comparison to say, one, the fact that infertility is found in both the genders in cystic fibrosis. Infertility is not found in female patients with respect to Carter-Negger syndrome. And why that is important is because it's a very minor detail, and he incorporated this in an MCQ bronchiectasis. Like, he put up three choices which were related to the lung involvement in these patients. And one of the options was related to the infertility. So we need to have a wide spectrum of manifestations. And the three diseases which are discussed here, all three of them have to be remembered: alpha-1 antitrypsin, cystic fibrosis, Carter-Negger syndrome on a comparison basis. These are genetic conditions which could contribute to development of problems for the patient. Then we could be having miscellaneous causes, which could be like yellow nail syndrome. This is a idiopathic condition in which the person would be having yellow brittle nails, not coileonychia, yellow brittle nails. Along with that, there can be lymphedema of the arms, lymphedema of the extremities, and recurrent pleural effusions. And to top it all, I can say the fact that in spite of everything that we have discussed here in the previous few minutes, in the textbook it is mentioned that as much as 25 to 50% of cases, in spite of the extensive workup that you do for this relatively rare pulmonary disorder, you will not be able to narrow down the cause for it. So these are the important list of causes that I want you to remember for development of bronchiectasis in a patient, and then we'll focus on the clinical domain. Now in the clinical part, they love to ask you regarding which lobes can be involved. So let's just make a quick list here with respect to upper lobe involvement. Tuberculosis is a simple straightforward answer. Then would be cystic fibrosis. Allergic bronchopulmonary aspergilloma. Do remember the fact that the first answer for allergic bronchopulmonary aspergilloma will be central bronchiectasis, though in some books it is mentioned that it will have involvement of even the medial part of the upper lobe. Then can be post radiation. So there are four important causes to be remembered for upper lobe involvement. If he talks about middle lobe involvement, then your first answer would be non-tuberculous mycobacteria. I'll talk about the treatment of them subsequently. Then would be Carter-Negger syndrome. I have already explained to you the infertility component of it. In fact, I want you to go back to this slide once again and remember the fact that you do not have infertility as a part of triad of Carter-Negger. The reason I explained to you, infertility is not a constant feature. No, it is seen in only one gender, that is male. It will not be encountered in a female patient. So infertility is not a part of the triad. The middle lobe is the one that is involved. The next one is unlikely to be asked, but still for the sake of completion, this disease that I'm writing is rare, and the problem with this one would be that the patient will be having a defect in the cartilage component. And because of the cartilage component being defective, they would be, I would say, deformed airways. Deformed airways means there is a defective ventilation, and because of defective ventilation, defective drainage of the lung secretions, bronchiectasis manifestations can be occurring in the patient. I repeat the fact once again: the architectural orientation of the airways with respect to the cartilaginous support that the airways should be having is not present in this condition. Let's now look at when would be the lower lobes be involved in bronchiectasis. In fact, overall, I said in the beginning itself, it's the lower lobes that will have relatively a higher tendency. So one of them is going to be recurrent micro aspirations that will involve the lower lobe of the patient. Then lower immunity, hypogammaglobulinemia, for which we will be checking for the specific antibody values. I mean, not only we will check whether these antibodies are present, but even quantify them. And then even interstitial lung disease. One of the histopathological subtypes of interstitial lung disease is idiopathic pulmonary fibrosis, and I've already sensitized you to the fact that that would be having manifestations due to fibrosis, basically called as traction bronchiectasis. Three words I want to highlight once again: dry bronchiectasis, right? Then is central bronchiectasis, and then is traction bronchiectasis. I mean, these are some of the terms that, I mean, the moment you read it, right, you should be spot on in answering. And once you've understood this, let's look at how the patient would come to you. The clinical manifestation in the question can be deliberately made by the examiner look like that of chronic bronchitis. He will begin by describing. He may even say smoker. Now, because I want to simplify things before you, so I'm not saying the word smoker or former smoker. I'm saying this particular chap, he may be recovered from a pneumonia, multiple episodes of pneumonia due to any reasons, could be genetic as well. So there's a productive cough present. Then there's a bronchoria, and every time there is an exacerbation. In fact, just like in COPD, you have exacerbations, like in asthma, you have exacerbations. This is also an obstructive airway disease where you can be having recurrent exacerbations. And with every exacerbation, what you will notice is that the purulence component will gradually keep on increasing. The secretions will become more fetid, much more foul smelling. So person will be having halitosis, bad smell from the mouth. He says that I brush my teeth regularly, but doctor, there's always a foul smell. And the sputum, especially in the morning hours, he produces very foul smelling purulent sputum. There would be breathlessness on exertion. When you auscultate this person, there would be crepitations or rales present. There can even be rhonchi present in these patients, though relatively less commonly. So I am just marking it here to say the fact that you can be having both crepitations and crackles in these patients. One of the, I would say, features that would be, peculiar to bronchiectasis would be that these crepitations will mainly be focused to the lower part of the chest in majority of the cases, especially with respect to infection, especially with respect to microaspiration. So when I talk about chronic bronchitis, in chronic bronchitis, I never said the word creps. In chronic bronchitis, I was mainly focusing on rhonchi. But when it comes to this disease, I'm not saying that this is an absolute way, but yeah, if you pick up these minor words, I think that you will be more comfortable. Like in chronic bronchitis, there will be absolutely no clubbing. And just to set the record straight, because you'll be wondering, I'm saying this again and again, so we need to put it on in black and white here. Smoker, bronchoria, repeated exacerbations that make the sputum relatively much more, I would say, purulent. Rhonchi being heard in the patient, both inspiratory as well as expiratory rhonchi, but no mention of clubbing. You have to think in terms of, if this is the data given in the question, you would be thinking in terms of chronic bronchitis. On the other hand, if you read a question where you definitely find clubbing present, though it's found in only 3% of cases, but still it's after all a finding. So if you read about clubbing, then you have to give benefit of doubt to diagnosis of bronchiectasis, and resolution will obviously be done with help of a HRCT in the patient. Because this is obstructive airway disease, it will contribute to hypoxia, so the person will feel tired all the time. There would be a weight loss, and subsequently cor pulmonale findings can occur in the patient. Cyanosis can be present even in these patients. That's why I said no. I mean, blue bloater. Blue bloater is chronic bronchitis, and even cyanosis can be found even in these patients as well. Subsequently, as the disease will progress, features of cor pulmonale, right ventricular failure, and pedal edema will occur in the patient, though with time, evolution of the disease, the severity of manifestations have become relatively lesser with respect to this disease. So now we will be focusing on workup of patients of bronchiectasis, and obviously imaging will be the first one that will be given a priority. If you do X-ray in early part of the disease, you will not be able to find any findings per se, but in the later part of the disease, obviously there would be a substantial increase in the bronchovascular markings that you can see. And apart from these bronchovascular markings, you can definitely see this horizontal involvement that would be called as tram track appearance, which is predominantly in the lower part. In fact, in this condition, this is a mixed variety where a cystic subtype, or I would say the saccular subtype, is also documented, apart from the distal part having presence of tram track appearance. So a very untidy looking X-ray. This initially, if I did not have the history related to bronchiectasis, I could have thought that this could even be a pneumatocele with a Staph aureus pneumonia. But if I have a proper history of months and increased bronchovascular markings with this cystic lesion, it's unlikely to be a pneumatocele, because that's gonna be within few days of a Staph aureus pneumonia, or he could have had a Staph aureus pneumonia developing recently, and then horizontally you can see presence of these airways which are going laterally. That would be the tram track appearance. Now, because of the fact that X-ray may not be so sensitive early on, so HRCT chest would be the best imaging modality for diagnosis of this patient. And you may be able to see cylindrical subtype, you can see varicose subtype, saccular in the same patient as well. So it's not like only one subtype, it's that usually or more commonly which is found in the patient would be the tram-track appearance. Now, once you remember this, because it's also easy, I'll say, he will try to incorporate a bit of radiology where he will talk about a signet ring appearance in HRCT chest of the patient. I'll just try to do my part, though I'm very sure you are aware of this from the radiological domain. Let me say the black is the representation of the airway. And then I've shown a blood vessel here. So I have shown a airway, I've shown a blood vessel. This is relatively normal, but in bronchiectasis, this airway will be grossly dilated. So I can say this looks like a wedding ring, right? So signet ring appearance coming up here because of the airway of the patient. In fact, I'll just mention the word airway here as well for representation purposes. The airway is relatively bigger. The definition has been asked in one of I think one of the previous DNB exams. Now you don't have a DNB, you have a NEET or a next coming up subsequently. So the question was that in a signet ring appearance, the airway diameter should be more than how many times the diameter of the blood vessel. I repeat the fact once again. What he asked was you take the diameter of the airway and then you compare the diameter of the blood vessel. The right is the blood vessel, BV is the blood vessel. So the diameter of the airway should be more than 1.5x the diameter of the blood vessel, and that would be the definition of the word signet ring. I repeat that fact once again. Airway diameter is more than the blood vessel diameter. Anyway, it's become much more than 1.5 times the blood vessel diameter. And just for so that you can remember this, I will jot it down. 1.5x of the blood vessel diameter should be the airway diameter. On radiology, obviously on CT they can measure it, so you will be able to identify the disease relatively easily. In earlier times when we did not have CT facilities, bronchography was mentioned, but now there is no point of giving any contrast to the patient. If you will do pulmonary function testing, it will reveal obstructive airway disease. And how do they represent obstructive airway disease in multiple choice questions? FEV1 divided by FBC will be less than 0.7. And there will be no improvement. Remember, unlike asthma where there is an improvement with bronchodilator, in this particular case, if we use albuterol, there will be absolutely no changes. So it's a permanent obstructive change. There's a damage to the cartilage of the airways. There's damage to the local epithelium of the airways. There's a component of bronchospasm also coming up, so that's where rhonchi can be heard. But even if you give bronchodilators, not too much of change would be seen with respect to this particular ratio. Then I'll be doing a sputum culture in the patient, which is anyway important because I have to start appropriate antibiotic for this chap. When I do a sputum culture, I will initially keep the sputum for the technician to come or for the microbiologist to come and then plate it on a culture plate. So if you keep the sputum for some time in these patients, you have a very interesting finding. That's the colonies of bacteria. The sputum, once it settles down, I mean the purulent part, purulence will settle down. So you will be able to see some concretions in the sputum, and these concretions are basically written as Dietrich. Just to draw parallels, like in asthma, I've talked about Cushman spirals. Similarly, here I'm talking about Dietrich plugs. The meaning of the word Dietrich plugs would be simply that these would be concretions which will be having colonies of bacteria plus some free fatty acids, and these concretions would be yellow and white and can be seen in the sputum culture bottle. Most of the time would be yellowish. I mean, that's the usual color that we get with the pus which is present in the airways of the patient. Apart from this, sputum microscopic examination in some of the cases might be revealing large amount of eosinophils. This would be specific for allergic bronchopulmonary aspergilloma. Remember, that was an asthmatic, so that's why eosinophils would be seen. Along with that, fungal hyphae can be present. I've already explained to you the fact that fungal hyphae can never be diagnostic of allergic bronchopulmonary aspergilloma because it's a hypersensitivity reaction. But this term has to be remembered. Dietrich plugs would be found in, that would be the fetid purulent sputum in a patient of bronchiectasis. And subsequently, I would also like to go into cause finding algorithm. So I will be checking for HIV for these patients. I can do a 4th generation ELISA for that. The advantage of 4th generation ELISA would be it will obviously incorporate P24 testing as well. And then subsequently, I will be doing an autoimmune panel. Like I taught you, Sjogren syndrome, rheumatoid arthritis, I don't need to write the tests for them separately. Autoimmune panel will save cost also and will help me in a quicker diagnosis for these patients. Then for genetic causes, we will be going in for alpha 1 antitrypsin quantitative assay. I've already explained to you it is produced, but then the release by the liver into the blood will be compromised. So the alveolar macrophages continue to produce elastase, and elastase causes local damage to the airways. Another important genetic cause was cystic fibrosis, and for that we need to go in for sweat chloride. Now, for sweat chloride, you very well know how do you produce sweat. How do you produce sweat in an individual? You will be stimulating the post-ganglionic fibers related to sweating by pilocarpine. So pilocarpine intophoresis would be used. For Kurtenegger syndrome, we need to demonstrate the cilia motility is defective. So most of the time you would be going in either for, you go for a nasal endoscopy, or you can go in for a lung biopsy of the patient. So either of the two of this patient can be done. We can obviously go and rely on histopathology for diagnosis of this patient. Nasal mucosa biopsy, especially from the sinuses, I can specify, and then from the lungs as well. But this may not be very, very conclusive, because after all, it's the motility of the cilia which is hampered. So we are nowadays having technology where we can go in for sending in a camera inside the sinus, or sending a camera into the lungs, and we can do a video microscopy analysis. I mean, look at the technology. You are sending a camera inside which is which can evaluate the microstructure of the lung, and it can evaluate the beating of the cilia, how many frames per second, how many beats per second. So this video microscopic analysis, obviously institutional base of foreign countries is where this would be better available, but these three tests that I've written in point number 7 would be primarily for genetic causes. Along with this, because hypogammaglobulinemia was one of the causes, so I can mention a quantitative immunoglobulin level for this person as well. Investigation number 5, 6, 7, 8 are mainly for finding out the cause, what could be responsible for it. And as I've told you, in spite of all the extensive workup we do, we may not be able to ultimately nail down the cause and call it idiopathic. For management of these patients, obviously antibiotics will play an important role. But in the exam, they would love to ask you regarding one of the causes for middle lobe bronchiectasis, that was non-tuberculous mycobacteria. The diagnosis of this can be made by bronchoalveolar lavage. But then subsequently, for treatment of these patients, you will obviously be not writing standard antitubercular treatment. You can be using macrolides like clarithromycin. Along with this, the drugs which would be used are rifampin and ethambutol. This is itself a multiple choice question. A person was detected to be having bronchiectasis, and in the sputum culture we had NTM being demonstrated. So which protocol would be best recommended for these patients? Now, because I was talking about a multi-pronged effort being used for management of these patients, and one of the very important weapons that you're having to manage these patients with bronchoria, and that to a purulent bronchoria. I mean, you see, antibiotics are limited penetration into pus. You can see I've not written the word antibiotic, though I've been talking about it. Because antibiotics have a horrible penetration into pus. So you need to ensure that your antibiotic reaches the desired site. So you will be using mucolytics for these patients. So the brand name, like I'm writing, is Dornase, or you would have read about DNase. The bottom line is this product has been found to be highly, highly effective in patients of cystic fibrosis specifically. Apart from this, I can say that I need to thin out the sputum. So I can be using 3% saline for the patient. The 3% saline will draw in water. So it will help in removal of those insippisated secretions, those stuck up secretions. So I just want to highlight this fact that lots of time, I mean, the patient might say that I feel so congested in my chest. That's because the secretions are stuck inside. They're thick, they're vested, and they're impacted on those in those proximal areas. They're just on the verge. They can be carved out, but they are impacted, they are insippisated. So those stuck secretions, I can be doing is 3% saline nebulization, and I can make them relatively loose and softer, so they can definitely be coughed out by the patient. And giving support here would be bronchodilators. I can be using LAMA, and that would help me with expelling the secretions. I'm not saying that bronchodilators will improve overall well-being of the disease. I'm not saying it's going to reduce the mortality. It's just that I am trying to ease off the so-called constriction in the chest of this patient. So what was the technology that I'm talking about? If you look at this image, you can see this looks like, some kind of a device, and this patient is wearing a vest. This looks like a bulletproof vest, in fact. Now this vest, what it is doing is, this is producing vibrations, and these vibrations, when they're from the outside, that these vibrations from the outside will cause dislodgement of the secretions which are stuck up inside the airways, and therefore the person will be able to cough it out subsequently. So chest physiotherapy plays a very important role, but this diagram that I've shown before you is of a high frequency. No, I'm not talking about a high frequency jet ventilation. We're not talking about ventilator at the moment. We are simply talking about a high frequency chest oscillatory device, and this will help in dislodgement of the secretions from the airways, and therefore the person will be able to cough this out. You see lots of time in our wards also, no? We when we go, especially and we handle our COVID patients or bronchiectasis patients, chronic bronchitis patients, we start doing tapping on the chest of the patient with our bare hands. But then this is a very, I would say, resource intensive aspect, because you need to dedicate a physiotherapist to do this for 15-20 minutes, and anybody will get tired, and I mean, it's a human tendency to shirk work. So most of the time, even if you assign a proper chest physiotherapist, you notice that they would either not be doing the work properly, or they may not be interested. But I would not like to rely on an individual. I would like to rely on technology. So a high frequency chest oscillatory device would be much more comfortable in this case. Along with this, obviously motivating the patient to use incentive spirometry. I would like him to exercise his chest muscles so that they are in optimal shape. If it's a geriatric age group patient, then the vaccines for the person should be definitely on, at least current scenario, COVID vaccination schedule of this person should be up to date. Whatever are the current recommendations, 2 shots should be taken. If he is a patient of hypogammaglobulinemia, then gamma globulins will also have a role. And then obviously comes the role of antibiotics. The antibiotics cannot be continued lifelong for any person, right? And that's understandable. Nobody would be willing to take antibiotics on a lifelong basis. So what we can do for these patients is, like, you can write ciprofloxacin 500 milligram twice a day for 2 weeks. So the medicine would be on for, let me say, in 1 month, 2 weeks he's taking medicine, 2 weeks he's off the medicine, by intermittent antibiotic clean out of the lungs. I repeat the fact, by intermittent antibiotic mediated clean out of the lungs, I will be trying to keep the infection at bay. I'll try to suppress the infection or keep it at the lowest level possible. We can also use macrolides on a daily basis, but there is obviously a practical issue. If you tell somebody to eat antibiotic daily, he or she may not be very comfortable, in contrast to when you give it on an intermittent basis. And obviously daily can also promote the development of resistance. In cystic fibrosis patients, there was an interesting approach. I know whether you paid attention to this, but I'm repeating it now, so this definitely should matter. You see, Pseudomonas, once it goes into the lungs, I'll have to use ceftazidime or piperacillin, tazobactam for the patient, expensive antibiotics. So I want to prevent the colonization of the airways. So what we do is, we can go in for a tobramycin nebulization in these patients. It could be once a week, depending on how intensive the disease manifestations have already occurred in a patient. But tobramycin nebulization in cystic fibrosis has been documented to prevent colonization of airways, and this single intervention is responsible for why cystic fibrosis patients in America are able to reach up to adult age group, whereas in our country most patients die. They don't reach up to adult age group. I mean, we were talking about infertility in cystic fibrosis. No, the question arises, why do you need to talk about reproductive issues in a person who can't even breathe? The point is, in India, they never reach that age group, most of the time. But abroad, that's one of the important interventions. So the message is prevention. He will say this word. How do you prevent the colonization in cystic fibrosis patients? Your answer is not tazobactam, piperacillin, and fancy stuff. It's tobramycin nebulization. We can also give IV antibiotic cleanouts for these patients. Like, we can tell the patient, you can come to our clinic. I'm not saying that get admitted. You come to the hospital, we put a IV cannula and we will give you IV antibiotics maybe twice a day. You have to come to our clinic, and we can do it for, let me say, 2 weeks a month. And then for 2 weeks, obviously he's off the cannula, he's perfectly fine. So IV antibiotic mediated clean out of the lungs. This strategy that I've said is repeated clean out of the lungs by the microbes would definitely improve the survival of these patients. And lastly, what I'm saying, listen to this with care. I'm not saying that steroids will be useful for treatment of patients of bronchiectasis. No, but if a patient of allergic bronchopulmonary aspergilloma is having an exacerbation, I'll definitely be using steroids. Worsening of manifestations in EBPA is managed with steroids, and I have handled aspergillus separately towards the end of the app in the infection segment. Go through it. Go through it. Why? Because in allergic bronchopulmonary aspergilloma, you will also read about itraconazole. So the query of yours will be, sir, should I answer itraconazole? Should you answer steroids? The point is, if it's gonna be exacerbation, it is steroids. If it is just saying how do you reduce the load in the lungs in ABPA with respect to the colonization that is occurring, then before the hypersensitivity reaction takes over and causes problems and there's exacerbation, I can reduce the lungs by using itraconazole. So both are used. If the MCQ says plain ABPA, it's gonna be itraconazole. If he says exacerbation, it is the usage of steroids. So a multi-pronged approach, if used for management of these patients, especially this particular device that I've highlighted before you, the high frequency chest oscillatory device, we will be able to improve the survival of these patients, and I would say improve the quality of life, and that's our job basically. So these are the details, guys, that I want you to remember. Keep the focus, keep learning, and I'm very sure all of you would come out with flying colors. Thank you for your patience and hearing me out.